Imagine, like, trying to safely inject a microscopic droplet of fluid into a tissue layer that's maybe no thicker than a few strands of human hair.
Right, which is already incredibly difficult.
Exactly. And now imagine doing that in a space that is highly sensitive, it's constantly subject to movement, and the actual structural topography of it changes drastically from 1 millimeter to the next.
Yeah, you're essentially flying blind in a highly volatile environment.
Right, and that is the reality of advanced aesthetic gynecology. So, welcome to the deep dive. Today, we are looking through a really fascinating stack of sources for you. We've got clinical training guides, medical spa protocols, and peer-reviewed studies.
And I have a very specific mission today.
We do. We are deconstructing exactly how the mesotherapy multi-puncture micro-droplet injection technique is physically executed. Specifically, how it covers the anterior vaginal wall and the introital ring.
Because, we hear terms like wellness or rejuvenation tossed around a lot.
All the time. It's such vague, soft focus language.
It really is. So
Yeah.
today we are moving entirely past that. We're looking strictly at the absolute millimeter by millimeter clinical mechanics of how doctors use microscopic amounts of fluid to basically regenerate tissue from the inside out.
Yeah, fluids like hyaluronic acid, PRP, exosomes. And the reason this matters and why the female intimate anatomy demands this level of scrutiny is that the space is just incredibly complex.
Oh, absolutely.
Yeah.
The mechanical delivery of the treatment is honestly just as critical as the medicine itself.
Mm.
A microscopic miscalculation in depth or even just the fluid pressure can completely negate the biological intent of the whole procedure.
Wow. So it's this crazy intersection of advanced cellular biology and highly disciplined motor skills.
Precisely.
Okay, let's unpack this. Before we get into the spatial navigation of the anterior wall or the introital ring, we have to talk about the physical parameters of the delivery method. The sources center around this concept of mesotherapy.
Right. And it's important to clarify, mesotherapy isn't a product.
Wait, it's not?
No, not at all. It's a delivery technique. It involves depositing material into the living dermis, or the submucosa, using short, ultrafine needles.
Okay.
You're making hundreds of shallow microinjections across a targeted surface area, rather than just doing one single deep injection.
Oh, I see. So it's kind of like, well, it sounds like hand watering a delicate garden with a really fine mist, right? Like
Yeah.
pointing the moisture exactly at the individual roots rather than just dumping a giant bucket of water on the soil and hoping it trickles down.
That's a great analogy. You are physically placing the regenerative material precisely at the depth where the cellular receptors are most concentrated.
Right. But, okay, pushing back on that a bit. If the goal is hundreds of perfectly distributed tiny punctures, why are we relying on the human hand for this? I mean, we have robotic surgery systems, right?
We do, yeah.
We have those automated skin booster guns that can fire dozens of needles at the exact same time at a perfectly calibrated depth. Wouldn't a machine be, I don't know, faster and more uniform for this kind of matrix?
Well, you would think so. In many medical fields, machine uniformity is actually the gold standard. But the clinical literature for intimate anatomy explicitly warns against it,
Really? Why?
because in the vaginal vestibule, uniformity is actually dangerous.
Wow. Okay, how so?
So automated injector guns operate on fixed depths, and they rely heavily on vacuum suction. The machine actually pulls the skin taut into a little chamber before the needles deploy.
Ouch. That sounds intense.
Right. Now, on the face or the abdomen, where you have a robust layer of subcutaneous fat, that suction is totally fine. It's well tolerated. But on highly sensitive, densely innervated mucosal tissue,
Oh, right.
yeah, direct vacuum suction on that kind of tissue amplifies the patient's pain exponentially.
So the mechanics of the machine itself are causing unnecessary trauma before the needle even breaks the skin.
Exactly. And furthermore, the structural thickness and the elasticity of the mucosa here, it's not uniform. It changes drastically from millimeter to millimeter.
I see. So a machine firing at a fixed, say, 1 millimeter depth just can't account for those shifts?
Right. Hand injection allows the doctor to recalibrate continuously. They adjust the angle and the depth point by point based on the exact tissue thickness they feel in real time.
Which means they can completely avoid high sensitivity zones like the clitoral hood?
Precisely. The objective is never the same depth at every point. The goal is the correct depth at each individual point.
Okay, that makes total sense. The delivery mechanism has to be as dynamic as the anatomy itself.
Hmm.
So now we know why the human hand is so essential here. Let's look at the tools in the physician's hand.
Let's do it.
The sources outline some really meticulous prep for this. What kind of needles are they actually using?
They're using ultrafine 27 gauge, 30 gauge, or even 32 gauge sharp needles.
Wait, 32 gauge. How small is that?
It's tiny. A 32 gauge needle has an outer diameter of roughly 0.23 millimeters.
Oh, wow. So it's barely there.
Yeah, it's exceptionally fragile. But it minimizes the mechanical tearing of the tissue when it enters.
Which is crucial. And because they're introducing materials meant to alter the biological scaffold, the prep has to be intense, right? You can't just walk in and get this done on your lunch break.
No, absolutely not.
Mm.
The area has to be thoroughly cleansed and disinfected. Then they apply a topical lidocaine anesthetic cream, which needs to sit for about 20 to 30 minutes.
Okay. And I saw in the protocols that for patients with heightened sensitivity, they might even do a tiny zero 0.1 mil lidocaine bolus at the entry point.
They do, yeah.
Yeah.
And the reason for this incredibly sterile, deeply numbed environment really comes down to the immune system.
Oh, how so?
Well, think about what's being injected, whether it's a cross-linked hyaluronic acid, like the Deserial product mentioned in the studies, or autologous PRP.
Right.
You're embedding a physical gel or a biological scaffold directly into the submucosa. If surface bacteria gets dragged into that mucosal layer by the needle, your immune system is going to freak out.
It's going to attack the bacteria instead of accepting the treatment.
Exactly. It immediately pivots to fight off the pathogen. You want the local macrophages and fibroblasts completely focused on integrating the hyaluronic acid, not fighting an iatrogenic infection.
You want to build tissue, not defend it. That makes perfect sense. Okay, so the canvas is prepped, sterilized, totally numb. The procedure actually begins at the outer entrance, right?
Yes, the introital ring or the vulvar vestibule.
And what's fascinating here is the depth challenge, because the injection depth here is just incredibly shallow. We're talking 0.5 to 1 millimeter into the tissue.
Which is microscopic. The margin for error is essentially non-existent.
Yeah, because if you go, say, 1.5 millimeters deep,
You've completely missed the target mucosa.
Yeah.
You end up in the deeper muscularis or connective tissue, and depositing the product there does absolutely nothing for surface mucosal dryness or elasticity.
and if you go too shallow, like 0.2 millimeter,
Then you're in the superficial epithelium. There just isn't enough structural integrity there to hold the fluid. The product will literally just leak back out the moment you pull the needle away.
oh man. So to hit that perfect 0.5 to 1 millimeter sweet spot, the doctor uses specific movements. The guides mention the fan array micro-droplet technique and the linear retrograde technique.
Right. They typically do about 6 injections distributed along the vestibule. So that's the anterior, posterior, and both lateral sites.
But wait, even with the numbing cream, how does a doctor manage the pain of multiple punctures in an area that is so dense with nerve endings?
It requires a very specific cadence. The clinical texts highlight this method called needle feel advance inject.
Needle feel, advance, inject.
Okay. The doctor isn't just rapidly stamping the tissue. They take about 3 to 5 full seconds per point.
Wow, that is deliberate.
It is. They are actively feeling the tissue's resistance against the needle's bevel. And they're constantly looking for real-time feedback from the patient.
To avoid pressure trauma.
Exactly. They deposit microbolus, just 0.01 to 0.02 mils per point for hyaluronic acid or exosomes, though for PRP, which is a lot thinner, they might do up to 0.4 mils.
Right, because if you force too much fluid into that submucosa too fast, the physical pressure of the fluid expanding actually tears the microfibers of the tissue.
And that rapid expansion causes sharp, acute pain that no topical anesthetic is going to mask. The slow microdosing prevents that entirely.
Okay, so that's the external entrance. But then the doctor navigates deeper into the vaginal canal to treat the anterior wall. And here's where it gets really interesting to me.
Oh, the spatial awareness required here is completely different.
Yeah, because the target shifts to about 2 to 3 centimeters inside the introitus.
Right, which corresponds to the mid-urethra and Helbin's fascia. This is highly vascularized tissue, often called the G-spot zone or periurethral plexus.
And the depth requirements completely change, right? Instead of that 0.5 millimeter depth, the doctor has to go deeper.
Yes, exactly, 1 to 1.5 millimeters deep into the submucosa.
Okay, but logistically, and this was my biggest question, reading the sources you are inside the vaginal canal, visibility is restricted. And you're often dealing with patients who have severe atrophy or hyperlaxity.
Right, where the structural walls are distorted.
Exactly. The tissue planes aren't where the textbook says they should be. So how on earth does a doctor visually or physically verify that they are exactly 1.5 millimeters deep and not, plunging into a blood vessel?
It relies entirely on tactile feedback.
Really? Just feeling it.
Just feeling it. Clinicians have to essentially read the tissue through the shaft of the needle.
That is wild. It's like a safecracker feeling the tiny tumblers click into place, but for human biology.
That is exactly what it's like. The different anatomical layers have very distinct physical resistances. The superficial epithelium has a slight drag. The submucosa feels spongy and compliant.
Okay.
And then the deep muscularis layer beneath it feels very dense and fibrous. So an expert clinician can actually feel those subtle microscopic changes in resistance. They know they're in the right spot when they hit that spongy compliant layer.
Wow. But they have to do all this while navigating around dense venous plexuses.
Yeah, and preventing an intravascular injection where you accidentally shoot the fluid into a vein takes intense focus. They rely on that micro-droplet dosing.
By injecting just 0.01 mils at a time.
Right. They inject a tiny bit and observe the tissue. If it blanches or expands like it should, they're safely in the submucosa. If there's zero resistance, it means the needle might have breached a vessel.
So they are constantly testing and observing. Okay. So the anterior wall is mapped, the final microdroplet is injected, but the procedure isn't actually over once the needle comes out, is it?
No, not at all. The biological mechanism requires immediate physical aftercare from the doctor.
Yeah, the sources mentioned a manual massage right after the injections, which honestly surprised me. It's almost like smoothing out wallpaper right after you hang it so you don't get any bubbles.
That's a great way to visualize it. If we connect this to the bigger picture, the rheology or the flow of these substances really demands that physical manipulation.
Because hyaluronic acid is so viscous, right?
Exactly. It's a thick gel engineered to hold water. And PRP is dense with cellular material. You don't want a localized lump sitting in one spot on the interior wall.
Right. You want an even hydrating scaffold.
Yes, dispersed laterally across the whole treated area. And critically, the massage prevents tract reflux.
Tract reflux. Okay, explain that one.
So every time that tiny needle penetrates the mucosa and pulls out, it leaves behind a microscopic tunnel, or a tract.
Okay.
Now, the tissue of the vaginal canal and vestibule is naturally elastic, and it's under constant tension. It acts kind of like a squeezed balloon.
Oh, so the tension of the tissue will literally just squeeze the fluid right back out through those puncture holes.
Exactly. So the manual massage collapses the structural integrity of those little tunnels. It seals off the micro wounds and disperses the internal fluid pressure.
Trapping all those valuable regenerative fluids safely inside. That is so clever. Okay, so the doctor does the massage, and then we get to the patient aftercare. And the protocols do not mess around here.
No, they are extremely strict. To protect those healing micro-wounds, patients have absolute restrictions for 48 to 72 hours.
Right, no sexual activity, no swimming, and absolutely no soaking in a bathtub.
You've just deliberately punctured the mucosal barrier hundreds of times. If you introduce physical friction or expose those open tracts to bacteria in bathwater, you're inviting a massive immune response.
Which completely ruins the whole regenerative process you just paid for.
Exactly. The tissue needs that 2 to 3 day window of absolute rest to close the tracts, peak its inflammatory healing response, and actually integrate the hyaluronic acid and the growth factors.
It's honestly incredible. When you take a step back and really look at what we've learned today, it completely shatters any preconceived notions about what aesthetic procedures actually are.
It really does. It's not just a generic shot.
Not at all. It's a highly customized millimeter-deep map of microdroplets. It's designed to rebuild tissue, hydrate the mucosa, and restore function to the anterior wall and introidal ring.
And, I think it leaves us with a really fascinating thought to ponder.
Yeah. Oh, what's that?
We are living in an era that is completely obsessed with medical automation, robotics, and machine-driven treatments, right?
Oh, yeah. Everything is moving toward AI and robotics.
Right. But it is incredibly ironic that the absolute most advanced regenerative therapies for female intimate health rely entirely on the manual tactile feedback of a human hand.
Wow, yeah.
The human touch is literally the only thing capable of reading that specific tissue millimeter by millimeter in real time.
The most advanced engineering tool we have is just the trained sensitivity of the human hand. That is a perfect final thought. Thank you so much for joining us on this deep dive into mesotherapy, everyone.
It was a pleasure to break it down.
Keep asking questions, keep looking past the surface, and always stay curious. Catch you next time.